am here.
I'm here, Dr. Durga.
Yeah.
Yes.
Shall I start, ma'am?
Yes, please.
Just
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Namaste everyone. I'm Dr. Rashmi Patil and welcome all of you for KSOGA Gynadeepa in association with the Kerala Societies, Trivandrum, Kollam, Kottayam, Appuza and the Adur Societies. I welcome all the faculty members and all the delegates here, and I request Shobha Gudi ma'am just to introduce to our webinars and speak a few words.
Yeah. Thank you, Rashmi. At the outset, let me congratulate Dr. Durgadas for carrying out this, as if it is a Olympic flame. He is doing Gynadeepa for so many societies, and I am really appreciative of what he's brought together. So many brilliant minds from all across India to conduct these sessions. And today, the topics are really mind blowing. It is recent advances in hypertensive disorders also, and it is something very close to our heart, hypertensive disorders in pregnancy. At the outset, let me welcome and let me say my pranams to the chief guest, Rohit Bhatt sir, a very endearing past president of Foxy. Sir has been such a gentle soul and so wonderfully soft spoken he is, and he really comes across as a guiding light for many of us. Thank you, sir, for attending the KSOGA webinar today. And then the guests of honor, the think tank from Kerala, Dr. P.K. Shekharan sir. Sir, welcome to KSOGA. We know you as the GTD person. Any reference for gestational trophoblastic disease, we turn to you for guidance. You have really mastered the subject and so many more things, sir. Thank you for being here. And my dear friend and my junior colleague, Dr. Kalpana from Madurai, really she has conducted such good conferences at Madurai, and I remember the one in Kodaikanal also. Thank you, Kalpana. Your work in infertility committee is going very strong. Thanks for being here. I also am very happy to see Dr. Rajashri here, the president-elect. And I must make a special mention of a person whom I look upon as my teacher as well, and that is Dr. Sarina Gilvas. I feel that she has such a wealth of knowledge and such fine surgical skills. We are very happy that she has come today, and she is going to speak on recent advances. Madam, thank you for coming here. And also, Virendra, thanks for accepting. You're so busy, but you have accepted to moderate a session, which is a panel, which is such a difficult task. Very heartening to see so many specialists from Kerala joining us. A very hearty welcome, warm welcome to all of you. And I wish you all the best, especially to Kunju Moideen and Radha. Keep working like this, and you will really see success in the near future. Thank you very much, Durgadas, for giving me this opportunity. Over to you, Rashmi. Over to you.
Much, ma'am. I now request our President Dr. Durgadas Asrana sir to introduce the chief guest of honors.
Good evening, everybody. This KSOGA Gynadeepa was started to collaborate KSOGA with other societies of the neighboring states. Like we started with Gujarat, now we have come to Kerala. KSOGA is going to have these programs with KFOG now. We had two programs with different parts of the Kerala. This is the third we are having, and for which I really acknowledge and thank the KFOG team for allowing us to do all these activities. Coming to today's program, I'm very happy that our beloved sir, Dr. Rohit Bhatt, has accepted our invitation. Uh, Sir, KSOGA is privileged to have you today. No words I can express my gratitude for you to accepting our invitation. About sir, he was the chief of the department of OB-GYN in PD, General Hospital. He was the past president of FOXI, NARCHI, that is National Association of Reproductive and Child Health of India, as well as he was the past president of ISOPAR. He had Lifetime Achievement Award for FOXI, NARCHI, and Harvard Medical School, and also ICOG. He was the chairperson of ICOG and also the chairperson of NARCHI. Past vice president of AFOG, BC Roy Award as an eminent teacher. He was the honorary fellow and national professor of National Academy of Medical Sciences. He was the former consultant to WHO, Population Council, Family Health International, John Hopkins University, and PCI. He was the editor-in-chief of International FIGO Journal of India from 1990 to 2006. He had several variations in India as well as abroad, more than 200 publications, and edited several books. With these few words, sir, I request you to address KSOGA as well as KFOG in this platform. Over to you, sir.
Am I audible?
Yes, sir.
Thank you, Dr. Durgadas and Reshmi, for inviting me. I have a long association with Kerala. I visited Kerala several times and
Karnataka, sir. Sir, KSOGA is Karnataka State OG Association. KSOGA is Karnataka State Obstetrics and Gynecology Association.
Oh, yeah.
We are from Karnataka, Bangalore, sir.
Right. So my son was in Bangalore as a vice chancellor. So I visited Bangalore 2-3 times, and my son is still there in Bangalore. I know so many of Shobha Gudi. Thank you for your kind introduction to me. And I'm very happy that you selected a subject which is of most importance. Because hypertension in pregnancy is a very important subject which takes a heavy toll of morbidity and mortality. It affects the growing fetus. And I'm sure we have got excellent speakers today to deliberate on this particular subject so that we can reduce the complications of hypertension in pregnancy. And I'm looking forward to attend to the speakers, and this session will be very interesting. Give my good wishes and blessings for the best progress of this particular session. Thank you.
Thank you, sir. About two speakers, Sarana Gilwas madam does not require any explanation. About Virendra Kumar, he had done lots of work along with his senior by name Suyajnan Joshi. They have worked a lot on low dose magnesium for eclampsia patients. They had lots of publications also. That was the reason I requested Dr. V. He is the professor in a government medical college. I requested him to be the moderator for the panel today. These are the two stalwarts of two speakers today, sir, which I wanted to bring to your notice. Virendra has done lots of work on low-dose eclampsia regime in cases of eclampsia in Indian scenario.
Good.
Okay, sir. Thank you. Thank
I'm
you, sir.
Looking forward to listening to them.
Yes, sir. Yes, sir. Coming to Shekaran, sir, PK Shekaran, sir, as Shobha Gudi has told, this is a GTD person. He was the former professor and head of the Department of Obstetrics and Gynecology in Government College, Calicut. He was the president of Kerala Obstetrics and Gynecology Association in 2003. He was the vice president of FOXI in 2010. He was the founder president, National Society for Study of Trophoblastic Diseases in India. He was the chairperson of 15th World Congress in GTD in 2009. He was a past secretary and treasurer of International Society for Study of GTD. He was a co-author, FIGO Guidelines on Management of GTD. He had 51 publications and 417 citations. More than that, presently he is in UK You can imagine what affection, what the commitment he is having. Now it's at 10 o'clock in the morning. He is he has joined with all the affection, sir. Kasoga, and on personal note, I thank you very much for coming and joining us today. Sir, a few words of wisdom.
Thank you. Thank you, Dr. Durgasraj. Thank you for your kind invitation. Uh, Good evening, sir, Dr. Rohit, sir, which I am very much happy to see you. And in our younger days, you are our guiding light and still continue to guide us in this field of obstetrics and gynecology. Thank you. I am very happy to share the platform with you. Doctor, congratulations, Dr. Durgadas, for bringing up this learning series and teaching series. I will say combined thing. It's a teaching learning series, and Dr. Shobha Gudi, the Secretary General, organizing such a wonderful series of webinars. We have got friends from Kerala. Dr. Sarina Gilgas is one of the best teachers, as I know her for a long time, and we are happy to listen to her. I hope Dr. Kunjumaidin is also there, and there are many people from Kerala who will be listening, and also from Karnataka. And thank you, Dr. Durgadas, for arranging such a learning webinars which will help us to. Today's topic is, as everybody said, is an important thing. Still continues to be the second important cause of maternal mortality in India as well as abroad. And the stress is on prevention as far as possible and early detection and treatment. So we are going to listen to the stalwarts. Thank you very much once again, Dr. Durgadas, for the kind invitation. Thanks.
Thank you, sir. Thank you very much. Now, our today's next guest of honor, Dr. Kalpana. She is from Madurai. Is CV She is the chairperson of Foxy Infertility Committee. She is a gynecologist and infertility consultant at Guru Hospital, Madurai. He was the course director for postdoctorate fellowship in endogynecology affiliated to MGR University, co-chairperson of Infertility Committee of TNFOG, vice president of Madurai OBJ Society, past president of Madurai chapter of TAPISAR, organizing secretary of MOG Silver Jubilee Conference in 2018, and many more, member of institutional ethical and principal investigator in clinical trials. She was a peer reviewer of Jogi and lecturer in CL Javeri Symposium in 2014. The awards what she is having are Best Doctor Award by Dr. MGR Medical University, Golden Excellence of International Award by European Continental University, Medical Excellence Award of 2018 from Governor of Tamil Nadu, Best Medical Service Award for Madurai District Collector, Best Committee of TNFOG Award from the Health Minister of Tamil Nadu in 2022, Nana Anemia Foxy Achiever Award, Foxy Badlao Appreciation Award, ISAR Rising Star Award, received Legend of Gynecology Award from Foxy President, and received Foxy UNICEF Appreciation Award 2024. Madam, Kasoga is really honored to have you today. Please have words of wisdom.
Yeah, thank you so much for the kind invitation, and it is always my honor to be a part of KSOGA family. This webinar is organized by uh, President of KSOGA, Dr. Durgadas sir, and Shobha Gudi madam as Secretary General, and my sincere thanks to other office bearers. President-elect Dr. Rajeshri and also Honorary Treasurer Dr. Shobha. My regards to Rohit Bhatt sir past president of Foxy. We really enjoyed the hospitality of Ahmedabad just now, and waiting to meet you again in Surat in this ISAR. It is my privilege to be here with the stalwarts. And my regards to Dr. Shekharan sir, who was president of Kerala Federation. I'm really happy that KSOGA is associated with Kerala Federation to organize such a wonderful webinars, and moreover, I could see Dr. Durgadas, Dr. Radhalakshmi, and Kunjumaidin had joined together to organize webinars, and my best wishes for their endeavor, future endeavor. I wish them best of luck. Durgadas is standing for Safe Motherhood Committee, I think.
Yes.
And Kunju Moidin, my national coordinator, is contesting for Infertility Committee. Dr. Radha Lakshmi, best wishes for you. You are contesting for
Ethics.
uh, ethics and medical legal committee. My best wishes, because this is second time for Radha Lakshmi and Kunju Moidin. So anyway, you have come together. My best wishes for you, and you have aptly chosen hypertension in this time. Hopefully all these tension will come down. We will have a healthy term baby at the end. Thank you again for including me in this webinar.
Thank you, madam. Thank you very much. With these few words, let us get into the topic of today. I request chairpersons to introduce our first speaker, Serena Gilvas, madam. It's only because of Shobha Budi I could get you. Really, I am thankful to you for coming. This is the topic. It's very close to my heart. Like I was talking to Bellal. Bellal is another person who does a lot of work on hypertension disorders in pregnancy. I requested him to join today. I don't know, probably he's still in the hospital. Madam, we are really honored that you have accepted our invitation to give this lecture. Over to the chairpersons. Rashmi?
Yes, sir.
Chairperson.
Yes, chairperson, sir, for today's session, Dr. Kunju Moidin, sir. He has 27 years of experience in the field of reproductive medicine, President Kerala Federations of Obs-Gynae in 2024, and Medical Director at the Birla Hospitals, and has been chairperson and organizing chairpersons also for the Yuva Kisar and many other international and national conferences as well. Welcome you, sir. Change the slide, see Arun.
Arun?
Slide change ಆಗಿಲ್ಲ ರೀ.
Arun?
Yes, sir. I welcome Dr. V. Radhalakshmi, Madam. She is Professor in Department of Obs-Gynae, Secretary Kurnool OBGYN Society, Foxy, and Zonal Coordinator for the NDRUHS Andhra Pradesh, and in charge of Mission Pink Health IMA Kurnool. Welcome you, ma'am. She has a lot of teaching experience and conducted regular full-day CMEs and many national state conferences as well. I welcome you, ma'am, and I request chairpersons to kindly introduce the speaker for today, Dr. Serena Gilvas, ma'am.
Can I introduce? Yeah, it is my privilege to introduce Dr. Serena Gilvas, madam. She is the teacher of teacher. I have seen madam in many conferences and many webinars. So I am very lucky to introduce Serena, madam. And she is a professor and senior consultant OBG department, Jubilee Mission Medical College, Thrissur. She is the president of Kerala Federation and Chairperson Board of Studies, Clinical, Kerala University of Health Sciences 2021 to 24, Captain of Maternal Death and Near Miss Surveillance and Responses, Thrissur District, Assessor of CRMD, ongoing, and place Madam is staying at Thrissur, Kerala, but Madam is well known throughout India, and I request you to deliver your lecture, Madam. Thank you. Sarina, Madam.
Thank you, everybody. Can you hear me?
Yeah.
Yeah, right. Our chief guest of the day, Dr. Rohit Bhatt. Our guest of honor, Professor Shekharan Sir, Dr. Kalpana. The president of KSOGA, Dr. Durga Das. Dr. Shobha Gudi, my very dear friend. Our chairpersons, Dr. Kunjumuddin and Dr. Radha Lakshmi. And the coordinator, Dr. Rashmi Patil. Friends, I think more than I would have to say, probably you will have more to say about hypertension in pregnancy. So I will just skip through some very important salient points, okay? Now, the most important thing today we talk about when we talk about hypertensive disorder is what are the predictors? Now, the predictors, more than the individual systolic and the diastolic BP, we talk about the mean arterial pressure. It gives us more information. And the mean arterial pressure is actually calculated as diastolic plus 1/3 pulse pressure. Okay, and anything more than 85 is significant. To say it is severe, more than 105. Okay, that is more than, or any 20 more than the normal MAP. Okay, 20 millimeters of mercury. So MAP is very, very important. Next, we come to the uterine artery pulsatility index. Now, when you say that, that tells us about the uteroplacental resistance or the uteroplacental side. So the uterine artery is so important. This tells us from the maternal side. Now, today, there is no preeclampsia without placental growth factor. Now, you would have heard about two angiogenic factors. One is the placental growth factor and the vascular endothelial growth factor. And today they say, especially in the United States, the NICE guidelines, which was in 2019 and updated in 2023, says you should have at least one PLGF associated screening from 20 to 36 weeks of pregnancy, anytime. And I'll tell you more about it. Then coming to PAPI. PAPI is another very important thing. Again, these products, the placental growth factor and the PAPI, which is pregnancy-associated plasma protein, they're all derivatives from the trophoblast. So it tells you a lot about the placenta proper. Now, we do not have many predictors which tells us about the VEGF, which I told you again is an angiogenic factor. But we know there are two anti-angiogenic. So that is the soluble FMS like tyrosine kinase like SFLT and the soluble endoglins. Now, these are all what we already know. Now, there is something new. You can check the plasma for glycosylated fibronectin in the mother. It's an early predictor of preeclampsia. So also in the urine of the mother, you can check the congophilic misfolded protein in the urine. That is again a predictor of preeclampsia to come. And so also when you see the ophthalmic artery, there is a reduced PI, okay? That again is a bad thing to tell you that she can go in for preeclampsia. So there are a lot of predictors, and today everybody is talking about screening and preeclampsia. But this is something which I really like. Let me tell you, this is by our own Foxy, the gestosis scoring. In fact, recently we have done the ICOG gestosis. I was part of the team under Dr. Bhaskar Pal. We have evolved the new format for HDP in India. So gestosis, I'll tell you, it is something which you all can put up in your outpatient. There is a low risk, intermediate risk, and a high risk. The low risk each has got 1 point. Very important, say the maternal age more than 35, or when she's too young, less than 19. Maternal anemia, obesity, all of us know, more than 30 kilograms per square meter. Any primies, a short duration of paternity, a woman born as small for dates, a family history of cardiovascular disease, polycystic ovarian syndrome, especially when she goes in for the metabolic syndrome, the inter-pregnancy interval of more than 7 years, And those who have conceived the ART, okay, if it is their own egg and thing, it comes under low risk. But if you take a donor egg, okay, then or a frozen egg, that becomes a high risk. Then when the MAP, as I told you, is more than 85 millimeters of mercury, chronic vascular disease and especially dyslipidemia, excessive weight gain during pregnancy. So all this carries a score of 1. When you say the moderate, we'll keep the moderate aside, we'll come to the high risk. High risk is each a score of 3. The pre-gestational diabetes, chronic hypertension, mental disorders plus schizophrenia, inherited or acquired thrombophilias, chronic kidney disease, we all know that's very important, autoimmune like SLE and APLA, etc., and rheumatoid arthritis, ART, as I told you, a donor egg or a frozen egg, all that is all high risk. So that's straightway 3 points. The moderate are the gestational diabetes, obesity, multiple pregnancy, hypertension, previous pregnancy, hypothyroidism, and family history. So actually, Gestosis has given us a very wonderful scoring system. Without anything, just from the history alone, we can come to a thing whether she's a high risk. So normally we say less than 3 is normal, more than 3 she's a high risk. Now, very important to tell you that if she's a high risk, we know that she's at the risk of developing preeclampsia. So what do? We all know there are 2 waves of trophoblastic invasion, okay? The first wave is between 8 and 10 weeks, and the second wave is between 16 and 18 weeks of pregnancy. So you should start aspirin before the second wave of trophoblastic invasion. So the ideal time, I'll tell you, that 11 to 14 weeks, around 12 weeks we start it. And after the aspirin trial, we all know that when you give 150 milligrams of aspirin, it prevents early onset preeclampsia. Remember that early onset preeclampsia is prevented about 60-68%. You can get a reduction if you start aspirin in the dosage of 150 milligrams to be taken at night. We start around 12 weeks onwards. So that is the importance of the Gestosis score. But there are so many other scores. Now, this Pierce model was actually preeclampsia integrated estimation of risk. This is actually put forth by Dr. Peter from the British Columbia University in Canada. He said mini Pierce, he said general Pierce, and the full Pierce. Okay, it is done in any gestational age, and the mini Pierce is done in low resource setting. Okay, and it will tell you where the person had a risk of adverse outcomes in up to 7 days before the complications arise. So it predicts the progress of the disease. So if you are in a low resource setting, you can transfer the patient to a better center. Application of this model into clinical care could improve the outcomes by assisting decisions around the timing of delivery also. So the mini Pierce, if you look at this, you can all look into it. It tells you about the gestational age and the symptoms of the patient, but there is no labs, no laboratory tests. So it can be used in low resource settings. The only thing that it tells you is a dipstick for proteinuria. All the others are just from the symptoms of the patient, okay? And so you can visit that website. So mini Pierce is actually done. The integrated scoring system is done in the low resource settings. But there is a full Pierce. Full Pierce is got from the gestational age, symptoms, and the labs. So it is done in a tertiary care center. So again, you can actually predict the thing. Now, if you ask me, okay, I've put everything together and I've brought out a scoring system which all of you can actually adopt in your day-to-day practice. The ideal scoring system, you can take the maternal risk factors. You should know the risk factors because then you know that these are the people who are going to develop. Check the mean arterial pressure. Okay, that's very important. Take the uterine artery pulsatility index. This 11 to 14 weeks is a good time to check the mean arterial. You can check it even at 20 weeks, but it's good to check it at 11 to 14 weeks scan. Then, as I told you, the placental growth factor and the PAPI. Even if you don't do PAPI, the placental growth factor by itself is fine. So these are 5 markers which any postgraduate can apply to in a practice as years go by. Okay. So if you do that, you can actually predict preeclampsia to a large extent. And as I told you, take the 11 to 14 weeks window. Now, when I told you about the PLG, if I told you the placental growth factor, such an important thing, NICE guidelines give a lot of importance to that. And if you take only that, okay, only that marker, it is said that if it is less than 12 picogram per ml, it's bad, okay? If it is more than 100 picogram per ml, it's very good. That means she's got adequate amount of growth factor. But if you want to take a ratio, you can take an anti-angiogenic factor like SFLT versus PLGF. You take a ratio, that is the anti-angiogenic versus the angiogenic factor. And if it is less than 38, that means the anti is less. Okay, it is less than 38, it is good. If it goes up, the ratio goes up to more than 38, it is bad. So these are all the various applications. You can take any one depending on your circumstances. Many people go for SFLT and PLGF ratio. So remember, less than 38 is good. That means the anti-angiogenic factor is less. Okay. Now, when you classify, I'm not going to, you know much more than me about the classification, but I just want you all to know that today we are taking 140/90 as a cutoff, and it's a persistent 140/90. Deshri told us that more than 140/90 persistence is very important. It is not just one off. So you can actually say when you take more than 140/90 4 hours apart, it doesn't matter, but a persistence. Just seeing once, don't start, warn her and check it again the next week. So anything after 20 weeks in a previously normotensive patient and which returns back to normal within 12 weeks postpart. Okay. Now this has been classified as severe and non-severe. You know, the task force has did a lot of changes. In that they realized that patients when they were non-severe, okay, 140/90 to 160/110, that is a non-severe category. They found out that, I have seen it in my practice also, they come with a BP of say 140/90 or even 130/90, and by night she comes with a convulsion to the labor room. So they said that anybody in the non-severe can become severe. So they said they have classified now only into two, non-severe and severe. In other words, if you know the severe, all the rest fall under non-severe. So the mild, moderate, severe has been taken off. Now, when you come to preeclampsia, now that when only hypertension, we call it gestational hypertension. But let me tell you one thing, there should be a good clarity in this. When that hypertension more than 140/90 with the significant proteinuria, that is more than 300 milligrams per 24 hours, this would be 1 plus dipstick actually, okay? Or if you take the urine protein creat ratio, if it is more than, that is equivalent to a 24 hours urine protein, it's a ratio and so it's more than 0.3. So there is significant proteinuria. If you ask me how we do in our outpatient, we do only if the patient is found to be hypertensive, more than 140/90, we go for a dipstick. And the dipstick, according to the RCOG, they have said that a persistent 1 plus dipstick, okay? But the ACOG has said even 1 2 plus is enough, good enough. Okay, 2 plus is actually, if you want to know in quantitative terms, it comes to about 1000 milligrams per 24 hours. Though we do not look at the quantitative value, I hope you all know that we do not look. So I want you all to remember one thing, hypertension with proteinuria is preeclampsia, that's for sure. But in many instances, we may not find a proteinuria, but we may find an end organ damage. So what are the end organs which we look into? The thrombocytopenia. If there is a thrombocytopenia, even if there is no proteinuria, I will call her a severe preeclampsia. Renal insufficiency with the creat more than 1 or 1.1. Liver involvement shown by the transaminase SGOT, SGPT. And if she's got imminent signs. So any of these things are present, we call it severe. Okay. So it is, we call it preeclampsia. And if it is, the BP is more than 160/110. And with these, then we call it the severe category. Now, when I tell you about the severe 160/110, remember, it is 160 systolic and 110 diastolic. So if you get a 160/90, also it is severe. If you get more than 110, say 150/110, diastolic is more than 110, even that is severe. That along with the end organs, as I told you some time back, every organ is there. The thrombocytopenia, then the liver is involved, the renal system is involved, there is the lungs are involved, pulmonary edema, and the cerebral system. So you find that any of these things, we call it as severe. So now we call them after the ACOG's task force classification, it is severe or non-severe. Now there is a chronic hypertension. Let me tell you one thing, chronic hypertension, if they come to me, I'm quite happy. Do you know why? Chronic hypertension, there's a chronic adaptation. And so they tolerate the pregnancy very well. But whereas the preeclampsia there is no time to adapt. That is why they show bad prognosis. So chronic hypertension, I'm pretty happy with the chronic hypertension. They tolerate even a higher BP. So it is a hypertension which antedates pregnancy or seen prior to pregnancy, or that which persists up to 12 weeks postpartum. But when I'm worried when a chronic hypertension has got a superimposed preeclampsia, that worsens the prognosis. Now, when do I say a chronic hypertension? Suddenly, she was very well controlled. There's a worsening of hypertension, or there is a new onset proteinuria, or she's got an end organ. Then I will say that it's a chronic hypertension with superimposed preeclampsia. The prognosis both for the mother and the babe is bad. Babe can have a lot of morbidities, mortalities, including FGR, etc. So that is why chronic hypertension with superimposed. And what are the three things I told you the superimposed? Worsening hypertension, new onset proteinuria, or an end organ damage. Okay. Now this looks like a busy slide. I don't want you to look at this, but what I want you to know is just three things in this slide. When a patient develops severe preeclampsia in the pre-viable state, that is before 24 weeks, stabilize her and terminate that pregnancy. Don't carry on that pregnancy. It is those which go on for maternal morbidity and mortality. So remember just two periods, less than 24 weeks, stabilize and terminate. After 34 weeks, severe preeclampsia, stabilize and terminate. But if they are the non-severe category, you can take them up as far as 37 weeks. So that's all I've got to tell you all, okay? So pre-viable state, stabilize and terminate. A severe preeclampsia, that is a severe variety, if it is beyond 34 weeks, best that you terminate the pregnancy. The non-severe variety, you can take up to 37, don't take beyond that. Now, this is the ISSHP's thing. I just tell you a few words about this. See, now, whenever a patient has got hypertension, what do? We start on labetalol. Okay, that's our first line. Now, we all know that labetalol is a alpha and a non-specific beta blocker. We will not give it when the patient is an asthmatic. We will also not give it if she's got, problems which is where there's a bradycardia or there is a conduction defect and all that. We will not give labetalol. Now, how do we start the labetalol? We start as 100 3 times a day, or 200 3 times or 4 times a day. Now, you look at that column, that high, okay? ISSHP says, don't go, if you've gone 200 3 times or 4 times, if the BP is not controlled, go to the next class. Don't go to the highest dose, which is 300 because you can, by all means, you can give up to 1200 milligrams per day. But before you go to that high, that's all that I want to tell you all. You immediately add on another drug. And the best drug that we would all give is nifedipine. Now, I must tell you one more thing about nifedipine. See, nifedipine, they have said PA, MR, XL, LA and all. It's nothing. It is the long-acting. What we give a pregnant woman is the long-acting or the extended release. But when she is in labor, and let me tell you one more thing, this long-acting ones, they come in the form of tablets. But when she comes in labor, you give the capsule, which is the quick acting. So remember, the capsule is the quick acting, the tablets are the long acting. So during pregnancy, we give them all this long acting. You can get 10 twice a day, thrice a day, increase to 20. And ISSHP definitely tells us that if she is taking only nifedipine, now many times we don't start on labetalol, we start on nifedipine as our first line. Then I will add on a labetalol. Okay, you can do either way, it doesn't really matter. Unfortunately for us, the methyl dopa is not available, so we will not talk about it. So the two antihypertensives which are oral, which are available to us today is labetalol and nifedipine. That's all I wanted to tell you all about that. Go slowly, go on increasing the dose. Don't go to that high level. Before that, add the second drug. And they say that when you have gone up to 3 class drugs, okay, and then if the BP is not controlled, it is time to terminate. Now, we all know that when we give the IV, we should not give it, as I told you all, it can cause neonatal hypoglycemia, neonatal brady, etc. So, give the labetalol very carefully. But it is such a wonderful drug. It is such a wonderful drug when the patient comes with severe hypertension. Don't give the oral tablets, give the parenteral form. Don't give the 10 milligrams, start off with 20. You start with 20 milligrams and give it slow IV over 10 minutes, okay? And if it is not controlled in the next 10 to 20 minutes, you can increase it to 40. Labetalol is a very good drug because it does not produce a steep fall. So you can increase it to 40 And then again, the next 10 to 20 minutes, if it's not controlled, you can start giving a 40 and 40, 80. Okay. Now I'll just tell you, you start with 20, then I make it 40. So it is 60. Then I give 80. So that makes it 60 plus 80, it's 140. Another 80 makes it 220. If I want to give another one more 20, it makes it 300. So you can give another 80 also, no harm. Though we say that 220 milligrams is the max dose, you can give another 80 milligram. And imagine this is all what you give slowly, monitoring very, 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 very carefully. Give it very slowly, okay? So that's how we give labetalol. And then if you want, you can give oral nifedipine. There is another drug which I have not mentioned in this, which is nicardipine. That is a parental calcium channel blocker. It will come to us. It will come to us. UK, they use it in large amounts. I hear somewhere in the north, they've got nicardipine. But as of today, we have got only parental form is labetalol. And the other which we give is the nifedipine. Nifedipine, please give it as oral capsules. Capsule, you remember I told you the rapid acting? Give it as oral capsules and you'll get the desired effect 10, 10, 10. And remember, when the patient comes with a very high hypertension, and even if she is convulsing, the first drug which I would give a patient would be the antihypertensive. Because a convulsion will not kill a patient, but the hypertension can kill. Supposing she comes at 240, 150, don't go running for magnesium sulfate. You give your labetalol first. You understand? And then you slowly, as I told you, 20, 40, 80, 80. If you want another one more, 80 you can give. So until nicardipine comes, we value the labetalol parenteral, and then we give the oral, not the sublingual nifedipine. Okay. Now, when we come to Maxilf, I just want to tell you just a few words about Maxilf. Now, we all know the precharge regimen. We give 4 grams IV of the 20%. So what we do is we can add 4 grams in 100 ml and run it over 20 minutes. That's fine. You can give that. So you're given the loading dose. After that, what the precharge regimen tells us is to give 5 grams intramuscularly in one buttocks and 5 grams in the other buttocks. So the loading dose is actually 14 grams. It's grams. It's not milligrams, it's grams. Okay. Now, there are various regimens. We in Kerala, I'd like you all to know that we in Kerala, we follow this KFOG regimen. We give 4, 4, 4. You know what? It's so easy to remember and so easy for everyone to follow. The first 4 grams, we give it in 100 ml over 20 minutes, right? Or you can give the 20%, whatever you want to say. The next 4 grams we give intramuscularly. So we give 2 grams in each buttocks. And then we start a drip with 4 grams, run at 1 gram per hour. It's such an excellent way to control hypertension, especially when the patient comes severe hypertension or when she's convulsing. That is very important, and that's the way we give it. But there are people who straight away start off on like the Zuspan regimen. They start with 4 grams IV and they give 1 gram per hour. So each is own. But what we have found useful in Kerala with the Kerala Federation is the 4-4-4. 4 grams IV, 4 grams IM, and 4. So when the IM, there'll be a slow release. You understand? So it will maintain a blood level. Now, why that magnesium sulfate, that blood level is so important is because we normally try to maintain a blood level of about 4 to 7 milliequivalents per liter. That is the blood level which will reduce a convulsion or prevent a convulsion. And we always monitor with 3. You know why we monitor with those 3 things? Magnesium sulfate is always excreted only by the urine. So if she has got a renal failure, what will happen to the magnesium levels? It will go up. So first the knee jerk will disappear, and then the respiratory depression, and then even a cardiac arrest can happen if it goes more than 15-20 milliequivalents per liter. You understand? So it is important for us to monitor. First, the urine output is important because urine output is the first indicator to tell us that there is some problem with the urine output, and so she could go for a renal compromise. But today ACOG has told us that you cannot say decreased urine output is renal compromise unless you see a creat of more than 1.1. Okay, I can understand that because when you give less amount of fluid, she'll throw less urine. It does not mean she's got a renal compromise. So you should see a creatinine also raised, only then you say it's a renal compromise. The second thing we check is a knee jerk. The knee jerk you should check because the first, when it becomes 8 to 10 milliequivalents, knee jerk disappears. So either you skip that dose, we give it as 0 plus 4, 0 plus 8, 0 plus 12. You can do any way that you want. You're always right. Any regimen that you all follow, you're always right. You are not wrong. Even some people follow the low dose, fine, you go by that. But what is important is either you skip that second dose, the 0 plus 4, or you can half it so that you reduce the level of magnesium. So these are all indirect ways of checking the magnesium levels. Do you understand? The knee jerk and then the respiratory rate. So the 3 monitoring, it's all indirect levels, indirect ways of checking your the serum levels of magnesium, which will take 3 to 4 hours to come. You understand? Now, that's all I wanted to tell you all about magnesium. So magnesium sulfate is very important. We give it in severe preeclampsia as well as for ineclampsia, okay? Now, we all know that when there is eclampsia or when there is, these are all maternal complications which you can have, cerebral hemorrhage. This is a killer. This is a killer. If your BP is very high, she can have a cerebral hemorrhage and you lose the patient. She can go for cortical blindness, especially when the retinal artery is thrombosed. She can have a retinal detachment, the kidney. Now that kidney, the acute tubular necrosis and cortical necrosis is important because in the tubular necrosis stage, you can still get back the kidney. So when the urine output starts dropping, think of termination. Please think of termination. Don't carry on that pregnancy because then she'll go in for acute cortical necrosis, which is irreversible damage to the kidney. Then you think of the liver, you think of the hematological problem. She can even go for de-isolator, the respiratory pulmonary edema, the dreaded problem, and of course, abruptio. Watch out for abruptio. Then we all know the fetal complications of prematurity, growth restriction, intrauterine death, etc. And the long-term problems. Indicators of severity, as I told you all, the systolic BP of more than 160 and the diastolic of 110, creat, thrombocytopenia, elevated serum amylases also can happen. I'll tell you that later on, the reason why we say that. Pulmonary edema, fetal growth restriction, all the impending signs, convulsions and oliguria. So all these are again indications to terminate. So I told you less than 24 weeks, stabilize and terminate. After 24 weeks, after 34 weeks, stabilize and terminate if it is severe preeclampsia. But before 34 weeks, if you find any of these severe problems, then it is best that you terminate the pregnancy. Don't carry on the pregnancy. At the most, you can delay till you give your betamethasone or your dexamethasone. And in less than 32 weeks, we also give magnesium sulfate for neuroprotection. Now, this is just one slide to tell you all, when we do not have to go for big imaging, but when will we go for an MRI? When there is, see, remember, eclampsia is a grand mal seizure. It is, the patient becomes unconscious also, and it is upper limbs and the lower limbs. All the 4 limbs are involved. So when you see a focal neurological problem, either it's just a focal convulsion or a focal neurological defect, then you must go for an imaging. When she's not come out of the coma, normally you know that there is a prodrome stage, there's a tonic, clonic, and then there's a coma, but normally they will revert. The coma will come round. But when you find she's not coming, maybe she's got a bleed. Do you understand? When there are recurrent convulsions not responding to magnesium sulfate, I want you all to remember that magnesium sulfate is an anticonvulsant only for eclampsia, not for an epilepsy or for any other probs. Okay? And when you see an atypical eclampsia, that is before 20 weeks or after 48 hours after delivery, these are 4 indications for imaging. A routine eclampsia does not require a big imaging. So focal neurological deficit, prolonged coma, recurrent convulsions not responding to magnesium sulfate, and atypical eclampsia, it's best that you do it. Now, I think this is my last slide. I just want to give you a little thing about the 3 differential diagnoses about HELP, okay? Especially when she goes into HELP many times. This is the hemolytic uremic syndrome. Now, there are 3 things which are common to hemolytic uremic syndrome and to the thrombotic thrombocytopenic purpura. What are the 3 things? One is they have microangiopathic hemolysis, they have thrombocytopenia, and they have a renal disorder. Okay, 3 things are common to both. But in hemolytic, uremic syndrome, there is severe renal failure. Please remember that there is severe renal failure. And so all what you have to do is you support your kidney, you take care of the IV fluids, whatever you're doing, and then sometimes you may require a dialysis. That's all that she will require. But in a TTP, Apart from the three things which I told you, that is the renal shutdown or the renal compromise rather, the thrombocytopenia and the microangiopathic hemolysis, she has also got neurological problems and sometimes even fever. So this is because when there's an Adams 13 deficiency, do you understand? So why the TTP is important for you to, so when you find thrombocytopenia, microangiopathic hemolysis as shown by your LDH, and if you find neurological symptoms in any form, okay, it may be a focal deficit, it may be seizures, coma, whatever, please remember what she requires is plasma exchange. What you're dealing with is not a preeclampsia. Do you understand? It is a thrombotic thrombocytopenic purpura. The third differential diagnosis, so you understood that HUS has got 3 and the TTP, the 3 things common with both are the microangiopathic hemolysis, the thrombocytopenia and the renal compromise. But what TTP has got is a pentad. It has got neurological deficit and fever also. Okay. Important when you see the neurological deficit, please go on to a plasma exchange very, very early. And of course, you can go for the glucocorticoids and the rituximab, etc. Okay, the MABs, the biologicals. So you can take care of that. The third DD which you must think of is AFLP. AFLP, I just want to tell you all, it's an acute fatty liver. You often find jaundice, which you might confuse with HELP. But please remember, in this acute fatty liver of pregnancy, you'll find that the serum bilirubin will never go beyond 10. Okay. The SGOT, SGPT will never go beyond 1000. And you will also find a refractory, low sugars, hypoglycemia. Let that warn you. And sometimes you might also get a leukocytosis. That's why we say the Swansea's criteria, we say 6 out of that. But just remember this. If you have got a patient with not so high the bilirubin, because if it is a hepatitis, she will have 6,000, she will have a bilirubin of 20, 25, 26, etc. But in an acute fatty liver, it will never go beyond 10. Okay, because there is no itis, there is no inflammation. It has gone in for an acute yellow atrophy of the liver. Do you understand? So that is why you do not get the high levels of thing. So these are the 3 differentials you must keep in mind. So friends, I didn't want to tell you all too many things about too many, but remember that preeclampsia is today associated with a lot of long-term outcomes. Most important, they say, is the cardiovascular. So all the cardiovascular probes have given their chronic hypertension, ischemic heart disease. So there is a long-term problem with this cardiomyopathy, thromboembolism, etc. She can have a repeat in the next pregnancy, then the metabolic and the neurological problems. So with this, friends, I conclude thanking you all.
Thank you, ma'am. I request the chairpersons to kindly make a remark.
Yeah, thank you so much, Sarina Madam. You explained everything regarding hypertensive disorders of pregnancy in a beautiful way, Madam. I'm also a teacher like you with working in government hospital.
Okay.
And you explained in such a way that you covered everything, Madam.
Thank you.
Thank you so much
Thank
for
you,
your great lecture, Madam.
Thank you. Thank you so much, Dr.
Madam,
Durgadas. Yeah,
thank you,
great.
madam. It is
And
such a clear cut,
one doubt, Madam.
One question was there.
Madam.
Yeah,
Very
sure.
clear
Yeah,
cut messages, madam. Very clear cut.
Thank you, Dr. Durgadas.
One question was there, Rashmi, on the chat box.
Yeah, tell me, ask me.
Rashmi?
Sarina madam, Shobha here.
Yeah, hi.
Fantastic presentation. I really enjoyed it, madam.
Yeah, thank you, Dr. Shobha.
Yeah.
I should thank Shobha now.
Yes, ma'am.
For getting
Yeah,
me,
you're
madam.
most welcome. No,
Yeah, for getting
really, you should not thank me. Madam is, so accomplished. It was very good for Kasogians to hear from her. So,
Rashmi, there was one question.
Yes, sir.
Even after 48 hours.
24 hours MaxSurf is given already after 48 hours. She has BP of 200 by 120. Should we repeat MaxSurf is the question, ma'am.
See, they normally say about the MaxSurf, if you have given it for eclampsia, yes, because eclampsia, what is the definition? You give MaxSurf until 24 hours after the last convulsion or delivery, whichever is later. That's very important. So if the convulsion has occurred later, you'll have to give it for beyond that 24 hours. But I'll tell you one more thing. When you're giving it for neuroprotection, you don't have to repeat. You don't have to repeat until after 1 month. If you have given it and then the pregnancy has gone beyond that, whatever, and she's still around 31 weeks or so, you can repeat after 1 month. Please remember one thing, too much of Maxilf is bad for the baby. It can cause osteopenia in the baby, in the newborn. So it's very, very important that we do not load her too much with. So normally we would have controlled, we would have delivered by then, etc. No? So remember that what the treatment is till 24 hours, whichever is later. If the convulsion is later, you'll have to continue till the last dose after the convulsion.
Madam, one question from me. How much the maximum dose oral for treatment of during expectant management, nifedipine, madam, you are giving?
I'll tell you what we give. Max, we give 60 milligrams. So we can give up to 120. We give 60, then we add on labetalol.
So you start first nifedipine, then you add labetalol.
Yeah, we always start nifedipine. No, it's nothing. No, nothing. But according to textbooks, labetalol is the first drug.
First choice.
First choice.
So labetalol max, you are using 200 mg or 300
3
mg?
times. 200 3 times. 200 3 times for labetalol. I'm talking about the oral, okay? And the nifedipine also we give 20. Sometimes I've given 4 times also. In fact, I should not say TDS and BD. I should say it is at 4th hourly, 6th hourly, 8th hourly, 12th hourly. That's how you give antihypertensives. It should not be given 3 times a day. It should be given 8th hourly, 12th hourly, 4th hourly, whatever your regime, whatever your orders.
Okay, thank you.
Rashmi, one more question is there?
Yes. Yes, post-delivery, can we start any other antihypertensives apart from the routine?
Oh, yes. I did not mention, I told you I have not covered the whole of things. See, post-delivery, these are the drugs which you can actually give. You can give labetalol, atenolol, okay? You can give Nicardia, you can give, AC inhibitors, okay? The 2 things we do not give is ARBs, that is your telmisartan and all those groups, ARBs and diuretics. These are 2 things we do not give postpartum. So you can give AC inhibitors, you can add atenolol, labetalol, Nicardia, nifedipine, all that you can give. There's no harm at all. But in fact, one of the first drugs which we give as an add-on is an AC inhibitor. We add an enalapril. Enalapril, it's just OD, BD dose. It's so easy to. But don't give ARBs. They don't recommend ARBs.
Yes, ma'am. Thank you so much, ma'am.
Thank you, madam. Madam, that's why you are teacher of teachers. I invited Dr. Shekharan sir and asked him at least wishes and go. You know what he told? I will stay at least while Cyrilla finishes her talk. That was the thing. Thank you, madam. KSOGA is really honored.
Thank you so much. You wouldn't mind if I exit, no, sir?
Thank you.
Okay. Thank you so much, ma'am, for all the clear-cut messages and a wonderful discussion on the recent advances. Thank you, ma'am.
Thank you.
We'll be beginning with an interesting session on the panel discussion. Mr. Arun, can we have the CVs?
Thank you, sir, for being with us. I asked Bella to join because sir will be there.
Madam has covered everything in a beautiful way. As she said and stressed, what we give as a regime is 444 because the recurrence of fit is one of the dangerous things. So the Maxilf is continued to prevent the next fit, which may be killing the patient. The first fit may not. So that's why if you give the IV regime as recommended in the Williams textbook and all, you give the loading dose of 4 gram and then continue 1 gram per hour. But the blood level will not be maintained and they are reporting up to 10% recurrence of fits, which may kill the patient. So that is why we thought that we may add on another 4 gram IM along with that 0 hour 4 gram IV. So the loading dose is 8. You know, in the IM regime, it is actually 14 grams are given, which is not there in the IV regime. So that's why we have seen recurrences with that dose. So we modified years back and we are happy to continue with that regime. And we recommend that as per our experience that You give 4 gram IV and then 2 grams on each butter, followed by 1 gram per hour. So this is where we are, and we call it as KSOGA regime, which is established by all our colleagues in Kerala. We recommend it because that is a result for us is there is no, after this regime, there is no recurrence. So recurrence of fits in an eclampsia is the one which is going to kill. The first fit may not kill, but the next fits may be the dangerous one. So it is important to prevent the recurrence of fits. And that's where she was given the very well explained how to give it, 4 gram IVs in 100 ml, given a duration of 20 minutes. That will be around 300 drops per minute. Then you can add 2 grams on either butter and continue with the 1 gram. Here again, 100 ml of normal saline, you put 4 grams and give 25 ml per hour with an infusion form. So we are all happy with this regime. So thank you very much. I was waiting to listen to Professor Serena. So I will take your leave. I am very happy to be associated with the KSOGA's program. Thank you, Dr. Serena, for explaining everything very well. I learned again and again whenever I listen to you. Thank you very much. So thank you all. So let me have the permission to leave. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
Can we have the CVs for the next panel discussion? And we all agree that hypertension in pregnancy can be very much well managed with adequate knowledge and the tips that I've given the expertise. To introduce with the panelists, we have Dr. Sudha H. She is President, Kollam Society of Gynae Prana Hospital, Kollam. Welcome you, ma'am. Dr. Anita K. Opal, ma'am. She is Professor OB-GYN, Government Medical College, Kottayam, Kerala. Welcome you, ma'am.
Thank you. Thank you very much.
Dr. Lalitambika, madam. She is President, Apoja Society. Welcome you, ma'am. Dr. Prasanna Kumari, ma'am. She is Chairperson of Safe Motherhood Committee of KFOR, Head of Department of Obs-Gynae at Adur. Welcome you, ma'am. President at Adur Society. Dr. Riti Rajan, madam. Secretary, Trivandrum Society. Welcome you, ma'am. Dr. Sajini S., Secretary, Kollam Society. Welcome, ma'am. Dr. Sushant Y.S. is Gynae Vaginal Laparoscopic Surgeon at SH Medical Center, Kottayam. I welcome you, sir. Dr. Deepthi P.S., Assistant Professor, Government Medical College, Alpuza, and special interest in high-risk pregnancy. Welcome you, ma'am. Dr. Meghana, Consultant Obstetric Gynecologist, and she is working with under eminent doctors and interested in the basic advanced laparoscopy also. I welcome you, ma'am. Dr. Sridevi H.S., Assistant Professor, Department of Obstetric Gynecology, Ballari. I welcome you, ma'am. And here we have Dr. Viren Kumar, sir. I welcome you, sir. He needs no introduction. He's been Professor and Head of Ballari Medical College Research Center. And we are very much aware about the Ballari regimen, President of Ballari Society in 2019 and 21. And we are here handing over this platform to you, sir, for the wonderful panel discussion. Welcome you, sir.
Thank you. Thank you,
Virendra, KSOGA thanks you, Virendra,
Thank
for
you.
taking
Thank you,
this.
sir, and thank you for giving me the opportunity to conduct a panel discussion on hypertensive disorders of
So your volume is a bit low, sir.
Now, madam?
We are not able to hear. We are not able to hear you clearly, sir.
Can you hear me now?
The volume is low, sir.
Can you hear me now? Hello?
I think directly if you can connect with the device only, sir, instead of using Bluetooth.
Can you hear me, madam?
Yes,
Hello?
sir. Yes, sir. Perfect,
Okay.
sir. Yes.
Actually, I'll be covering some of the important points which are already fully deliberated by Professor Serena Gilwas. And most of the things have been already told in an elaborate manner by Dr. Serena Gilwas. However, we want to drive home some practical points to the audience. Hence, I'll be asking our eminent panelists about the certain basic aspects of hypertensive disorders of pregnancy. So I will share Can you see the screen now? Hello?
Yes, sir. Yes, sir.
Okay.
Make it full screen. Slideshow.
Yeah. So at the outset, I welcome our panelists, Dr. Sudha, Dr. Anita, Dr. Lalitambika Madam, Dr. Prasanna Kumari, Dr. Reeti Rajan, Dr. Sajini, Dr. Sushant, Dr. Deepti, Dr. Sridevi, and Dr. Meghan. So without wasting time, let us go to the first case. This case, the question will be go to Dr. Sudha Madam and Dr. Anita. A 35-year-old gravid to paravan with severe preeclampsia is 8 hours post-cesarean section. Total fluids given since surgery is around 3 liters. However, urine output is only 10 ml per hour for the last 3 hours. Pulse is 110 per minute. BP is 170 by 110 and SpO2 is 93%. My question to the eminent panelists would be, because the urine output is low, should we give bolus of IV fluids to improve further, or should we directly go for Lasix?
No, we need
and
not.
What advice for Dr. Sudha, madam, please?
The IV bolus is not indicated in this case because already we have given in a pre-eclamptic case, already 3 liters is given, and the overload is shown by the SpO2 is reduced to a lower level, 93%. And the preeclampsia being a condition where the intravascular depletion and the interstitial overload. So no need. If at all the case is bleeding later, PPH is there and hypovolemia shows, only small test bolus is to be given at the dose of 250 ml of crystalloids per hour.
That means there is no role of bolus.
In this case, there is no need.
Okay. What about furosemide?
Furosemide we can give in this case because it is shown, as I told, the SpO2 is lower and it is showing early sign of pulmonary edema. So in this case, we can give.
Dr. Anita, madam, what is the advice for IV fluid administration for preeclamptic patient?
So preeclampsia is a condition where the intravascular volume is less, and also there is a capillary leakage due to the problem with the endothelium. So better to reduce the dose or control the dose so that 60 to 80 ml per hour is enough for the patient. And the urine output, if there is a reduction in the urine output, that is due to renal vasospasm and not due to the hypovolemia. So giving much of fluid or more fluids to this patient won't help you in creating more urine.
Yes, as the eminent panelist told, so there is no need for giving bolus. One should remember that in hypertensive disorders of pregnancy, we have leaky capillaries. So whenever leaky capillaries are there is no role of giving too much IV fluids. Pulmonary edema may precipitate either because of the leaky capillaries or because of the diastolic dysfunction of the heart. If there is no breathlessness and creatinine is stable permissive limit, then oliguria is acceptable. Just because oliguria is that, don't try to give either furosemide or try to give bolus. Restrict fluid, as Dr. Anita madam told, it is less than 80 ml per hour should be given. If there is evidence of breathlessness for the patient, you must give injection Lasix 20 to 40 milligram IV. Thank you, madam. So the next question to Dr. Lalitambika and Dr. Prasanna Kumari madams. A 31-week primary gravid has epigastric pain. Blood pressure is 150 by 90 and platelets 90,000 per microliter, and she has elevated AST. She has not received steroids. This is the clinical scenario. So what is the dilemma? Should we deliver her immediately or should we wait for 48 hours for steroids? Dr. Lalitambika madam. I think she's not joined. I don't know. Dr. Prasanna Kumari?
Because she has epigastric pain, yes, feature of impending eclampsia, she should be treated as impending eclampsia. She should be started on magnesium sulfate. Of course, we can give 1 dose of dexamethasone, but because the platelet is falling less than 1 lakh, it's better to think of terminating pregnancy.
Okay, so you want to deliver her immediately? She's only 30 days.
And the trend in platelet can be repeated, and this liver enzyme also can be repeated frequently. And if it is falling, then of course we have to terminate as emergency. Otherwise, we may go in for severe help.
Dr. Lalitambika madam or any other panelists can answer the any opposite view if it is there. Madam wants to deliver immediately after giving magnesium sulfate. Any other views?
We can give steroids, I think, because it is 31 weeks. Giving a dose of steroids
that is already
will give
said,
a
no?
lung maturity.
We can give her dexamethasone and then start thinking of terminating. Okay. And the trend in platelet and liver enzyme, you can see, you need not wait for 24 hours to repeat.
Yes.
You can repeat frequently. Decide.
Yeah. This is actually class 2 HELP syndrome. If maternal condition, fetal vitals are stable, we can wait 24 to 48 hours. However, if the epigastric pain is very severe, sometimes there may be a mild discomfort in the epigastrium. Then you need not rush to deliver her. But if the epigastric pain is severe, then it may actually suggest stretching of the liver capsule. So in such cases, as madam told, immediate delivery is mandatory. If the discomfort is minimal and the enzymes are not very much elevated and the permissible limit of platelets, definitely we can give Dexona. At least you can wait for 24 hours and deliver. Thank you, madam. The next case, that is case number 3, the question goes to Dr. Riti Rajan and Dr. Sajini S. Primary gravida with 36 weeks of pregnancy with 200 by 130 millimeter of mercury without any symptoms. What is the diagnosis? Dr. Riti Rajan and Dr. Sajini can answer how to manage such cases. Dr. Riti Rajan or Dr. Sajini can answer.
Can we pass to the next panelist, sir?
If they are not available, yeah, please. It can be answered by anybody. Dr. Sushant or Dr. Deepthi. Or even Prasanna Kumari madam can answer, or Dr. Sudha can answer.
Can be started on intravenous labetalol. Because
what is the diagnosis? 200 by 130.
It is impending. I mean, she may go in for it. She may throw a fit. And
Okay.
it is preeclampsia only. We have to
But she
immediately
doesn't have symptoms.
bring down the BP.
Preeclampsia.
Okay. How do you manage?
IV labetalol, see, is Anitha answering? You are not audible. Anitha, you turn on your mic.
Okay, madam. Okay, madam.
Okay.
Yes.
We have to control the blood pressure with IV labetalol, 20 milligram we can give first, then check the BP and later on give 40 milligram if needed.
Okay. Suppose BP is not controlled with labetalol. Sometimes we come across such situation. You are giving labetalol, you give 20 milligram, 40 milligram, 60 milligram. Nothing is working for us.
Add on the drug. Add on a second drug.
What like?
Nifedipine. Or you can
Nifedipine.
start on or we can start on NTG.
Nitroglycerin or sodium
Hydralazine.
Okay. So actually this case to be called as hypertensive crisis, acute hypertensive crisis. So anything which is beyond permissible limit is called as hypertensive crisis. So either there is urgent or emergency. If the patient has got end organ damage in the form of cortical blindness or breathlessness or some symptoms, it is emergency hypertensive crisis. If there is no symptom, like in this patient, it is urgent, wherein you have to control the blood pressure within 30 minutes to 1 hour. If you don't control, patient is likely to go for cerebrovascular accident. So as madam rightly told, you give IV labetalol 20 milligram and again repeat after 20 minutes if there is no control. Or else you can give oral nifedipine. Okay. So sometimes IV labetalol may be contraindicated in the form of asthma or cardiac block. In such cases, you have to give, you should not use labetalol. Patient is asthmatic or cardiac block or heart rate is already low. Don't give labetalol. These three things are very important. Previous history of cardiac block, asthma, or if the heart rate is low, don't give labetalol. You can use oral nifedipine. Sometimes oral nifedipine may also not work and labetalol also may not work. In such cases, we have used IV hydralazine. You can give 0.2 milligram to 0.3 milligram per minute. Okay. So we get 20 milligram of hydralazine. You add 100 milligram of hydralazine in 500 ml of normal saline, and it becomes concentration of around 200 microgram per ml. So the dose is, just to simplify, 0.2 to 0.3 milligram per minute. When IV labetalol or oral nifedipine is not working, then IV hydralazine is probably safer than NTZ. But if you don't have experience in using hydralazine, you can use nitroglycerin drip. So let us move to the case 4.
Dr. Virendra Kumar, I am Dr. Prasanna. I had to leave for an emergency in the theatre.
Yes, ma'am. Please. Okay, thank you. So the case 4, Dr. Sushant and Dr. Deepti. Emergency LS is required for a woman with 160 by 100 millimeter of mercury and platelet dropped from 90,000 per microliter to 55,000. What anesthesia would be given for such patients?
So here, according to the guidelines, when we have to take a patient for LSCS under regional anesthesia, the platelet count should be at least 80,000 per microliter. So here it is only 55,000. So we may not be able to put her under regional anesthesia, so may need general anesthesia.
Okay. So what is the risk of general anesthesia?
What, pardon, sir?
Risk of general anesthesia in such patients.
Risk of general anesthesia, the BP is high. So when we give regional anesthesia, there can be a drop, but here the BP is high, so there is high risk for induction of anesthesia. But since the platelet count is there is high risk for we are giving regional anesthesia. There can be hematoma, spinal hematoma risk is there.
Okay. So
the operative bleeding risk is higher if you give general anesthesia.
Yes, Sushant. So actually what happens, this is very common scenario in medical colleges where junior PGs, second year PG will be giving anesthesia, and sometimes senior anesthetists may not be available. So spinal hematoma risk, as rightly told, definitely is there when the count is less than 70,000. And more so in this case, it has dropped from 90,000 in the morning to 55,000 in the afternoon. So definitely spinal anesthesia is contraindicated. It must be general anesthesia only. But the problem with general anesthesia, sometimes it can, during intubation and extubation, there can be hypertensive crisis. So blood pressure has to be well controlled in such cases. Otherwise, the general anesthesia itself may exacerbate the hypertension. So safer limit is 70,000 per microliter for spinal anesthesia. And in this case, the general anesthesia is definitely safe. Thank you. And let us move to the question. Question number 1 to Dr. Srivedi. Dr. Sridevi, every time we hear in our rounds PH case like that, it has become almost incorporated in our day-to-day conversations. Should we retire the word PH? Dr. Sridevi.
Yes, sir. Yes, sir. Definitely, we should retire from the word PIH and start using HTP, hypertensive disorders of pregnancy, as suggested by ISHSP, and classify them according to gestational hypertension, preeclampsia with severe symptoms, preeclampsia without severe symptoms, and chronic PIH with superimposed symptoms.
Yes.
Because
so
PIH
as rightly
is
told, yeah, continue. Actually, the word pH is obsolete now. We should no longer use the word pH because there are so many etiologies are available for hypertension during pregnancy. So better word would be HDP, hypertensive disorders of the pregnancy. We all practitioners as well as teachers and postgraduate students should refrain from using the word pH. We should use hypertensive disorders of pregnancy as a broader umbrella, or use a specific word like gestational hypertension or preeclampsia or chronic hypertension like that. The next question, Dr. Sudha Madam. Gravida 3, para 2, living 1 with 5 weeks of pregnancy and telmisartan presents to you with 150 by 100. How do you manage?
We have to stop the telmisartan.
Okay.
Because it is an ARB drug and convert into nifedipine or labetalol. Oral is enough in this case.
Okay. So this is obviously this is a case of chronic hypertension. What is the effect of telmisartan on pregnancy, madam? On baby?
Renal effect.
Okay. Renal disorders or renal
Damage
dysfunction can occur. Yes, renal damage can occur. So immediately it should stop
the telmisartan.
Yes. So this is, see, you cannot call this patient as PH. Nowadays we are getting so many such cases. That's why, as rightly told by Dr. Devi, we should not use the word PH. It should be obsolete from our practice. So to Dr. Anita, the question is Gravida 3, Para 2, living 0 with 170 and 110 millimeter of mercury with 30 weeks of pregnancy is admitted. How will you manage? Dr. Anita?
Yes, sir. This is a case of early onset preeclampsia with severe symptoms. So we have to control the blood pressure as well as we have to give some Maxerf to prevent convulsion in this case. And we have to monitor the patient, all the investigations we have to send and monitor the baby as well. If possible, we have to continue till 34 weeks, or in the meantime, if she develops any other complications, we have to terminate the pregnancy.
Okay. So even though it's 170, 110, you will not jump to terminate the pregnancy, right?
Yes, sir.
Okay.
We can wait for some time.
Yes. Even any case of severe preeclampsia, as long as possible, keeping the safety of mother in mind, we can continue up to the period of viability, as Madam rightly told, up to 34 weeks of pregnancy. They would continue. Suppose you admitted a patient, and how long you think they can pull on with this kind of blood pressure, ma'am?
So even after our management, the BP is remaining like this, we have to terminate, irrespective of the baby's condition, because it is for the mother's sake.
Suppose if it's not controlled with labetalol, what will you do? How much labetalol you will use?
Here in this case, we have to give IV labetalol, and then if it is not controlled, you can add nifedipine as well.
170, 110, do you think we should give IV labetalol? Most often they will settle with oral antihypertensives now, unless there is an emergency or some symptoms or diastolic is very high. Dr. Sudha, madam, what do you think? Should we give IV labetalol in such patient?
What, sir? We can start with 20 mg, slow IV, taking a time of 20 minutes. You check the BP again. If it is not controlled,
should we give IV labetalol or not in such patients?
Oral. You are asking about oral. We can start with 100. We can start with 100 milligram dose.
Yeah. So in such patients, probably most of the time they'll get controlled with oral antihypertensives. Only if the diastolic is very high, not getting controlled, or some symptoms, we can use IV labetalol. Thank you, Anita madam.
Thank you, sir.
The question next to Dr. Lalitambika: when should be the aspirin be given as prophylaxis, and what dose, and when to stop it? I think Lalitambika madam left, I think. Dr. Reeti Rajan can answer. Or the question is open to anybody, any panelist can answer, please.
As early as 12 weeks.
As early as 12 weeks. Okay. Suppose patient comes
while doing an NT scan, when we do a screening, you can do a combined test with the preeclampsia screening test. The TIGF you should also do. That gives you a risk of.
So the question is when should be, and I'm not asking why, what all conditions because all of you know, the best idea would be before 16 weeks.
Before 16 weeks, sir.
Before 16 weeks. So that is the best window to give, depending on, suppose sometimes if you are dealing with Apler syndrome cases, they are usually started as soon as the pregnancy test is positive, or some people start when the cardiac activity is once is established. Okay. In most of the cases, as Dr. Sushant told, it would be given around 12 weeks at the time of NT scan. if there is a high risk factor or if patient is screen positive. The best is whenever you give before 16 weeks.
Before 16 weeks.
Suppose if patient comes at 18 weeks, 20 weeks, what will you do? It's a very common finding, especially in rural India. Patient may come at 20 weeks.
Up to 20 weeks, we can give because that will give some protection.
Okay. So up to 28 weeks, you can give according to FIGO as well as ACOG criteria, but best window is before 16 weeks of pregnancy. So should we give 75 milligram or 150 milligram?
150 milligram. 150 is the recommended dose.
150. What about 75? Because some of the old practitioners were using 75. They were happy with 75. So,
it's a body weight. It's
yeah. Sometimes some of our patients are very thin, like 40 kg, 50 kgs. In such patients, you can use 75. Though, as per the aspirate higher, it is 150 milligram. Still 75 milligram is also equally useful. But if there is a definitely high risk factor is there, some high risk factors are there, you can give 150 milligram. Otherwise, you can give 75 milligram. So next question is to Dr. Riti Rajan. What antihypertensive you prefer in antenatal management of disorders of pregnancy? In the order of preference. Dr. Sajini can answer if she is there. Or Dr. Sushant can also answer.
I think you should start
order labetalol.
Okay.
Nifedipine.
Then nifedipine.
Okay.
Then, if available, M-dopa can be given. Alpha-methyl-dopa can be given.
Okay.
Is alpha-methyl-dopa available nowadays?
Alpha-methyl-dopa is slowly making an exit from the market. Most of them, it is taken over by labetalol. So you can use nifedipine also. Sometimes patient is already on beta blockers like atenolol, metoprolol. Can we use that?
No, we cannot use it in pregnancy.
Sometimes it is well controlled because patient is already on metoprolol, or I think it can be given if they are already on under well control. Even though per se, if the obstetrician wants to start, we usually prefer to use labetalol. Sometimes patients are well controlled, especially chronic hypertension patients. They are well controlled with even amlodipine. So we can continue to have amlodipine because already by the time they come to us, organogenesis is over. If it is well controlled with amlodipine, still you can continue to use the amlodipine. It is also calcium channel blocker, though we have limited data. Okay. So from obstetrician point of view, labetalol, nifedipine, and methyl-dopa. Or in cases you can use oral hydrolysin also. Thank you, madam. The next question, what are the differential diagnosis of HELP syndrome? I think Serena Gilvas madam made it very clear, but just for the sake of completion, what are the differential diagnoses?
Hemolytic uremic syndrome.
Yes.
Acute fatty liver of pregnancy.
Yes.
Thrombotic thrombocytopenic purpura.
Yeah, correct. So because already there are sometimes the findings of thrombocytopenia, anemia, or some kind of hyperbilirubinemic may overlap with each other. In such cases, we have to keep this in mind, especially acute kidney injuries more common in hemolytic uremic syndrome, which may not be seen in other cases. Whereas in TTP, neurological symptoms will be there. So one pathognomonic symptom or finding of each cases will help us to rule out other case from HELP syndromes. So what is PRESS, Dr. Sushant?
Since that reversible encephalitis syndrome, whatever. So it happens after the delivery. So the patient after delivery goes in, suddenly she becomes, disoriented, and all those CNS symptoms will be there. And MRI findings, last year findings will be there.
Okay.
Actually, it is not very common.
What is the treatment for this?
I do not know.
So it is another form of severe preeclampsia, or sometimes we can think that it may be equivalent to eclampsia. It is actually neuroradiological diagnosis. the moment press comes, you must use the word, it is a neuro-radiological diagnosis. The patient has some kind of giddiness or cortical blindness or some high blood pressure. So when such patients are subjected for MRI or CT scan, you have occipital cortex hypodensity lesions are seen. So that's why the press is always, it is neuro-radiological diagnosis. Just by clinical suspicion, we cannot make press. And most of the times it is reversible. And the treatment is you have to control the hypertension and we have to give magnesium sulfate, because magnesium sulfate enhances the vasodilatation and improves the cerebral perfusion. Okay. Thank you, Dr. Sushant. Now, the question to Dr. Deep. What are the predictive
Hello, sir. You're
for
not
pre-eclampsia?
audible clearly. Hello?
Can you hear me?
Am I
madam?
audible?
Yeah, you are audible.
Audible,
What
okay.
are the predictive tests for pre-eclampsia?
So there are various predictive models. So the importance is that we can predict early because the signs and symptoms may not be shown up before severe preeclampsia can occur, and the importance is that we can predict and do surveillance and time the delivery. That is the importance, and it's one of the major cause of maternal mortality. So we have to have some predictors, and the Fetal Medicine Foundation algorithm has is there. You can download it free. It includes the maternal characteristics plus the mean arterial pressure, the uterine artery pulsatility index, and placental growth factor. Based on this, the Serena madam has already discussed, and this is recommended by the ACOG and FIGO. You do at this along with the 11 to 13 week scan. So along with the ultrasound, you can do the uterine artery pulsatility index, and along with the beta HCG and PAPA, you can send the placental growth factor. And when the value of more than 1 by 100, it's a positive predictive value for development of preeclampsia. And the one drawback is it can predict early onset preeclampsia. The person is 90% predictive value is there, but for late onset preeclampsia, the values only 47% can be detected by this algorithm.
Yes, as it has been already discussed by Dr. Serena, but most importantly, you should proper history must be taken. Historical factors should be considered.
That maternal care risk factors are there. High risk factors include the history of previous preeclampsia, chronic hypertension, renal disease, and all these autoimmune diseases, type 1 and type 2 diabetes. They have high risk factors. High risk for any one high risk factor, we have to start low dose aspirin. That is important. So we can prevent the progression of preeclampsia.
Yes, correct. Historical factors are very important, and high index of suspicion by the clinician in the absence of the biomarkers like PAPA or beta HCG levels, or sometimes
placental growth factors.
uterine artery mean PA may not be available for majority of Indian women. In such cases, high index of suspicion and historical factors are more important than relying on uterine artery PI or biomarkers. Okay, thank you, madam. The next to Dr. Meghana. Apart from aspirin, are there any other intervention to decrease preeclampsia?
Yes, sir, absolutely. Other than aspirin, there are other agents like low molecular weight heparin, and in our setup, in Indian setup, more females are more deficient in calcium, sir. So 2 gram calcium intake also will help in significant reduction of preeclampsia, sir.
What about using fish oil? What about using L-arginine supplementation?
Yes, sir. They are also helping.
Chinese herbal medicine is also there. Can we give all those things?
No, sir. They are not proved under studies, sir. Once the studies have finished, then we can conclude those.
Okay. As
But
Dr.
L-arginine has vasodilation actions.
So as Meghna told, the only known interventions to decrease blood pressure are, one is pharmacologically aspirin prophylaxis, another one is calcium supplementation. That too, calcium supplementation who are already deficient in calcium in their dietary supplementation. So these are the only interventions who are statistically significant to decrease the hypertension. But most of other, whatever you give, including improving the micronutrients and herbal medicine and fish oil, all those things, they are anecdotal. There is no recommendation to routinely use these things in our day-to-day practice. The only practice is calcium, but the thing is, most of the women do not take these tablets as advised. 2 gram means almost they have to take 3 to 4 tablets per day. Okay, but wherever in well-motivated patients, we can use 2 gram per day, either in the form of supplementation or in the form of dietary supplementation. Thank you, Dr. Meghna. Again, the next question is, nowadays we talk about a word called as atypical preeclampsia. What do you understand by it?
Atypical preeclampsia is more of where preeclampsia exists with non-classical presentation, where they present without having hypertension and proteinuria, sir. It will be more, the presentation will be more related to endothelial leakage like pleural effusion, facial edema, pulmonary edema, and other. The presentation include other features like nausea, vomiting, headache, and all. So elevated liver enzymes, low platelet count.
So this is a very common scenario in our day-to-day practice. Patient is otherwise fine, or our only symptom could be edema, but when you see her blood pressure is typically normal, but they behave like a preeclampsia patients. That's why the word atypical preeclampsia is coined by the researchers from Australia and New Zealand. The researchers in the field of hypertension, especially from Australia and New Zealand, they advocate the use of word atypical preeclampsia. And for us, preeclampsia means always there should be blood pressure. Hypertension is the sine qua non of diagnosis of preeclampsia. But what happens most of the time, patient has got proteinuria, or she may have only bloated up. Our blood pressure is perfectly all right. In such patients, the researchers say that you treat them as if they are a case of preeclampsia. So that's why the word atypical preeclampsia is there. Probably these patients need to be put on under high surveillance. So patients, it's a very common practice in our day-to-day. Hello, ma'am. Can you hear? Can you hear me?
Yes, sir.
Hello?
Yes, we can hear you very clear.
Okay.
Yes.
So atypical preeclampsia should be always kept in mind in managing any pregnant woman for that matter. Okay. So if I will share this article to many people, always keep this in mind so that the morbidity and mortality of hypertensive disorders of pregnancy is never missed. Okay. So there may be normotension, but still patient has proteinuria or platelet count may be low, or she may be fully bloated up because of the leaking capillaries. So these patients should be treated as if they are a case of preeclampsia, and they must be put on under high surveillance. So the next question is to Dr. Sridevi. What do you mean by persistent postpartum hypertension? Usually expect hypertension to go down once the delivery occurs, or maybe maximum. Dr. Sridevi.
Yes, sir. Sir, if usually after delivery, blood pressure usually comes down. If the blood pressure is very high, post-delivery up to 6 weeks to 12 weeks, and which it requires any intervention to prevent maternal mortality, is termed as persistent postpartum hypertension. It can be again reclassified into early immediate persistent hypertension and late persistent hypertension, and chronic hypertension. Immediate is when the blood pressure after delivery is very high and it comes back to normal within few hours after delivery. and late persistent hypertension, which takes up to 2 to 3 weeks post delivery. And if blood pressure doesn't subside after 12 weeks of delivery, then we have to label it as chronic hypertension.
Exactly. So all of us, we know that preeclampsia is a latent manifestation of cardiovascular disease. It should not be, that's why we don't call it as pregnancy-induced hypertension. These are the patients who are likely to become cardiovascular patients later in life. So don't take these pregnant preeclampsia patients lightly. Majority of the women will become chronic hypertension later. That's why the word persistent postpartum hypertension is very important. So the why I'm calling this is there is a lot of importance for follow-up of such patients, because there may be renal causes for persistent postpartum hypertension, or there may be cardiac cause. So just don't be happy by delivering them. Definitely you should follow up them so that we don't miss persistent postpartum hypertension patients. The last question in this panel discussion to Dr. Sridevi. What are long-term sequelae of preeclampsia and in whom it is more common to occur?
So
Dr. Sridevi?
long-term complications, consequences of, yes, sir. Sir, am I audible, sir?
Yeah, you are audible. Please go ahead.
Yes, sir. So long-term consequences of preeclampsia not only affects the mother, but also affects the offsprings of the mother with the preeclampsia, sir. So we have to keep both in mind, and maternal complications, as we all know, hypertensive disorders of pregnancy. The mother who's diagnosed with hypertensive disorder, she's had tenfold increase in cardiovascular risk. So she'll have cardiovascular diseases, sir, and she's more prone for heart failure. She's at risk of developing type 2 diabetes mellitus, and she's 5 to 10 times more. She's more risk for developing chronic kidney disease and neurological and mental illness at the later age of life. And they may also experience premature aging and dementia, sir, in mothers. And coming to offspring, sir, we have seen that they experience in the offsprings they have autism. The offsprings of the mothers of pregnancy-induced hypertension, they experience autism. They have neurodevelopmental conditions like autism, ADHD. They're more prone for all this, and they're also prone for cardiovascular risk and metabolic disorders in the later age of life. And they also experience obesity. It is more commonly seen in female offspring. They experience obesity, and male offsprings, they have testicular atrophy, decreased testosterone production in the male offspring.
So considering it is looking at your long list, it is really scary to treat preeclamptic patient. But again, it is a reminder to all of us that don't take preeclampsia that only delivery cures it. But in fact, you should use this opportunity to educate the patient so that they don't suffer from such sequelae later in their pregnancy. And the Canadian researchers actually call preeclampsia as a cardiac disease. And to our surprise, we had actually conducted study, especially in primary gravida who are severely preeclamptic. 60 to 70% of the patients had echocardiac abnormalities. There was something or the other in the 2D echo. Okay, so this proves that, according to the Canadian researchers, actually preeclampsia is nothing but a latent cardiac disease. So I think still our understanding about the disease is incomplete. However, we should all update our knowledge by attending such seminars so that the patients are benefited in terms of decreasing the morbidity, mortality, so that we contribute ourselves in improving the women health in India. And some 4 points: don't chase the urine output during preeclampsia, chase the breathlessness. If the lungs are clear, the kidneys will eventually catch up. And restrict IV fluids to maximum 80 ml per hour. This is one of the pearl point. Don't chase the urine output, chase the breathlessness, especially SpO2 monitoring is very, very important for the first 24 to 48 hours. The window for aspirin is early. If you have not started by 150 milligram by 16 weeks, you have already lost 80% of the preventive benefit. So please start, if at all you want to start aspirin before 16 weeks. So another pearl is every severe range of blood pressure, 160, 110 is a stroke waiting to happen. Is a stroke waiting to happen. Treat it within 15 minutes every single time. Otherwise, sometimes patients I have seen, they come with 200 by 130, they are not at all perturbed. It is like a ticking time bomb. Please treat vigorously, especially the severe hypertension. Preeclampsia, as Sridevi rightly told, it doesn't end at delivery. Actively pursue long-term effects and active and advise preventive measures. That's why postpartum follow-up should never be forgotten for preeclamptic patients. Just don't be happy by delivering them and just forget them. So thank you, sir, and thank you all the panelists for participating in this. And I really thank Dr. Durgadas Sarana sir for entrusting me this job to share some of the points on hypertensive disorders of pregnancy. Thank you, sir.
Thank you, sir.
Thank
We
you,
have two
Gynadeepa,
questions
sir.
in the chat box,
Thank
sir.
you so much.
So the question in the chat box are, what platelet count should platelets be transfused in case of HELP patient prior to LSAS or induction of labor?
See, the criteria is very simple. If the persistent, if there is no threat of declining platelets in vaginal delivery, if it is more than 50,000, no need to transfuse platelets. Suppose if patient is being taken for cesarean section, if the count is stable at 80,000, no need to transfuse platelets. So for LSAS, if it is less than 80,000, transfuse. For vaginal delivery, if it is less than 50,000, transfuse.
Okay, sir. One more question is, what is the best drug for persistent hypertension postpartum?
So postpartum, usually our general drugs like labetalol and nifedipine, they won't work much. So probably you can use the ARBs like telmisartan, or sometimes you can use potent anti-beta blockers like atenolol or metoprolol. So we have found metoprolol to be more useful in treating postpartum hypertension. Because the advantage of using beta blockers in the postpartum period is these patients, because as I told, they are probably latent cardiac disease there, they are prone for arrhythmias. If you use beta blockers in the postpartum period, the chance of having arrhythmias or unrecognized abnormalities of the heart rhythm can definitely be prevented. Hence, we have to use preferably beta blockers, probably potent beta blockers in the postpartum period.
Yes, sir. Thank you, sir. Shobha Gudi ma'am, would you like to add something to this?
Virendra, wonderful performance, Virendra. Lots of take-home messages. You fulfill my desire. Like every question was filled with the practical aspect points, and you have conducted very nicely. And the panelists, all of them, you have done wonderful job. Thank you from the KSOGA office. I say thanks to each and everyone who have participated in this program. Rashmi, thank you.
Thank you, sir, for involving us in this webinar.
Thank you, sir, from my side also.
Thank you, sir. Thank you so much.
Thank you. Thank you. Rashmi, vote of thanks.
Organizing wonderful organization, sir. And Dr. Shobha Gudi ma'am, I think requested her. Madam is there, sir?
Illa.
No, madam.
Okay. Yes, sir. So we had wonderful discussion about the hypertensive disorders in the pregnancy. We'll be mindful in writing this terminology in comparison to PIH in our future cases that we are going to see. A lot of good take-home messages and practical tips and points that we have got from all the extremely knowledgeable faculty members, panelists. Thank you so much, sir, for the wonderful sessions that you have conducted. And thank you, Durgadas, sir. Thank you, Mr. Arun, for conducting this webinar for.
Thank you.
Thank you, madam.
Thank you, everybody.
Thank you, sir.
Thank you.
Thank you.